And then it's a great honor to introduce to you the next speaker of today. He's the chair of both the Geriatric Department and Geriatric Research Group at Ramón University Hospital in Madrid, Spain. His team has been working in geriatric nutrition, mainly leading the European definition of sarcopenia, which is still the most commonly used and most commonly cited definition. And he also is working on a definition of sarcopenic obesity. So please welcome to the stage Professor Alfonso Cruz-Jentoft.
Good morning. Thank you for inviting me to Amsterdam and for being here. I've been asked to present an introduction to the rest of the day about the relevance, why we are here. I think I shouldn't speak much, because if you're here, you already think sarcopenic obesity is relevant for you. But if you have a look, this is some 2 weeks ago, the World Obesity Day. And you see, of course, the figures are impressive, about 2 billion people having obesity and lots of children and lots of expense. But if you see, in all the marketing of that day, they don't mention all the people, and they don't mention sarcopenia or sarcopenic obesity. So this is still a research field, and it's not in clinical practice, and we hope we will be there. Why sarcopenia and obesity, and as I will explain later, bone, come together? They come together because we are talking about body composition. When we go to sarcopenia, also a special function that the muscle has, that's movement, not only the metabolic aspects or the nutritional aspects. And we have these kind of graphs where what we know is that we usually have an increase of fat and a decrease of muscle when we age. This is shown in different ways and in different aspects depending on what you see, and they usually go up and then down, but it's also quite evident that it's different by gender. So here you can see that fat mass and body mass are different in the pink part, which is females and males. So this is something that we are not being aware enough, and we have to think more about. And if you look at what we're seeing is this kind of models. There's something that goes up, in this case, muscle mass or bone. It goes up, and then it's maintained or lost along life. It depends on the peak you reach, which for muscle mass, it depends also on gender. Because in our species, males have a peak which is somehow 30% higher than females, and that might explain why females are more disabled when they grow old. And then we lose it depending on nutrition, exercise, and diseases. And we may reach a peak where we lose physical performance, and then we lose ability to do things. That's disability. Interestingly, this theoretical model, both for muscle mass and muscle strength, has been confirmed. The loss of strength is much faster and earlier than the loss of muscle mass. And this is what we now have the modern concept of sarcopenia. We'll still read sarcopenia as equivalent to low muscle mass. Please forget, low muscle mass is low muscle mass. Sarcopenia refers to function. But from the nutritionist point of view, what we're doing, in fact, is using the same device to see different compartments. When you perform a DEXA and you get the report, in the DEXA report, you get all the three elements: bone density, lean mass, and fat. So it makes sense that they are related. They have to have a relation because we are measuring them with the same device. And if you look at the different phenotypes and what happens on age, this is adult and older people, you see that we have an increase of fat and usually a decrease of mineral, and that's bone, a decrease of proteins, and a decrease of water. That's in general, but each individual will behave differently, and we have to take that into account. This graph that was shown by Peter before shows the 4 general situations you can find when you check fat and mass together. And of course, everybody would like to be there. Low adiposity, high muscle. That's good. It's something that seems to be healthy and attractive. There's also these people with high adiposity and a high muscle mass, both. They call dad bobs now, and you can find a list of the 20 best dad bobs in internet if you like that. Most of them are famous actors. That's an interesting condition. We need to study more, because this obesity is bad, but they are saved from disability by muscle. Then we have low adiposity, low muscle mass. This is cachexia, and in many cases sarcopenia. This is not good. This is very unhealthy. But then we have this group with high adiposity and low muscle mass. And this is what we're talking about. This is the sarcopenic obese group. If you go and look at the prevalence of the phenotypes, what you see, this is high adiposity, low mass, that it goes up both in females and males when you age. And mostly in males, you see around 10%, 11% for both. So this is a reality we're seeing. 1 out of 10 older people will have both conditions at the same time. And that's why you are here, because you're seeing these patients and you're probably a bit confused. Of course, the three elements are related. When you have muscle loss, fat gain, and bone loss, the fat goes everywhere. And in fact, there's some people that discuss about osteosarcopenic obesity, although there's some criticism to this concept of blending all this together. But this criticism, in fact, makes biological sense, and this will be better explained by Professor Boiry later, because if you look, the three components come from the same mesenchymal cell: adipocyte, osteoblast, and myocyte. So if they're in the optimal environment, what you have is an increase in muscle and bone, in muscle mass and in bone formation. This is good, and you keep your fat controlled. But when you grow old and you have diseases, there's a dysregulation of this. And this dysregulation, by aging and also by sedentary lifestyle and low-grade inflammation, what it does, it reverses these good things. It reduces muscle mass and bone mass, and it increases adiposity. So there's a biological basis to where we're talking. And we know that muscle and fat crosstalk, usually through inflammatory pathways and also some endocrine pathways. And when one gets sick, the other one suffers, because they are talking between each other and they have a relation. And you can find these kind of things, and this is for Professor Boiry, who's the biological expert, but there are many intertwined pathways that we're still trying to understand and try to find which is the best one. But at the end of the day, sarcopenic obesity comes from many aspects of adipose tissue dysfunction, inflammation, lipotoxicity, and all of them damage the muscle, so they come together. Who are at risk for sarcopenic obesity? The people at risk are older people, because in many cases there are factors associated with aging. And you see here physical inactivity, poor quantity and quality of nutrients, chronic low-grade inflammation, and then disease and things that happen to you, including barriers to nutrition in many underdeveloped countries. By the way, a summary of all the day would be this very recent article by Carla Prado and colleagues on sarcopenic obesity in Nature Reviews Endocrinology. I've used 2 or 3 of the slides, but I recommend you printing it and reading it as a summary of the full day. Is sarcopenic obesity bad? Yes, it is, because it has both the adverse events of sarcopenia and the adverse events of obesity blended in the same person. So you find an increased mortality both for cardiovascular disease, and because sarcopenia is also linked with that, morbidity, and morbidity includes cardiovascular and things like arthritis, because it's related to movement, metabolic, cancer, and many other aspects, including hospitalization, falls, reduced quality of life, and disability. So this is bad. Okay, now you're all confused. You say, a lot of data, this is research, so what is good for me to understand in clinical practice? How can I put this together? So as you're clever people and you study and you research, as many of you, you go and read the literature and try to find out what's happening. So you go to the first European consensus on sarcopenia, and you find that it mentions that fat mass may be preserved or increased, and this is called sarcopenic obesity. It mentions here intramuscular and visceral fat, but that's all. It mentions it exists, nothing else. Then you go to the new one, and again, it mentions reduced body mass with excess adiposity, and it says it's a distinct condition, but it's not in the scope of this article. Okay, so I can't use the sarcopenia consensus to understand that. I'll go to Asia. Asian people are clever and they might have. But again, they say there's osteosarcopenia, sarcosteoporosis, osteosarcopenia, but we will not recommend criteria. So that's, again, not the right place. So you go to guidelines. You say, if you treat sarcopenia, you have to consider some of them are obese, I think. So you go, and even neither the old one or the very recent Australian and New Zealand guideline, which is an excellent evidence-based guideline, they don't mention sarcopenic obesity. So if you come from the sarcopenia field, you won't know what to do with those. So you go to obesity guidelines and say, let's see if the people working in obesity tell me what to do. Well, in this European guideline, which is one of the most recent, sarcopenic obesity is not even mentioned. It's not mentioned. And if you go, this is a nice paper, an obesity position statement by the NASO. And in this statement, it mentions that the current data show that weight loss therapy improves physical function, quality of life, and medical complications associated with obesity, but weight loss therapy that minimizes muscle and bone losses is recommended. So it says, be careful when you have an obese person who's old and is losing weight, there might be a problem with the muscle and you have to do something different. But then you go, how do I define obesity? And you have a problem because if you go to the WHO, which by the way doesn't mention sarcopenic obesity, and you see overweight is greater than equal to 25. But evidence tells us that the lowest mortality in older people consistently is around 27, 28, 29. So this would be overweight people by the definition of WHO, but they have the lowest mortality if they are old. In old age, having some increased body mass index seems to be safer than having a reduced or a... So the limit is, again, confusing. This explains why recently many researchers coming from nutrition, geriatrics, and obesity in particular tried to change the field. This was a call for action. It's only 2018, so it's quite recent, saying we need to do a lot of research, which is what the SONATS is doing, sarcopenic obesity, and all the limitations and needs, including diagnostic tools and criteria, basic knowledge, how to prevent and treat. This will be Professor Boiry and Professor Exler later on. They will be discussing these aspects and where we are now. This group, what we made first is what's people using to define obesity, sarcopenic obesity, in the papers published. And in this systematic review, we found all these ways to measure sarcopenia and all those ways to measure obesity. So it was absolutely inconsistent. We couldn't use that. This explains why finally, a couple of years ago, there was a consensus, European consensus group trying to better define. Please note that this definition needs to be better validated, but it's a proposal on how can we define that. This is the idea. The idea is you start by screening, and the screening starts with finding there's something related to obesity, for example, a high body mass index with these caveats. I don't know why they're moving alone, sorry. And then you define sarcopenic obesity by two elements. One element is having low muscle strength, which is the current definition of sarcopenia. And the second, a better definition of obesity than using only body mass index. And then you define severity, and severity is that one that has complications. And complications are either obesity complications, which are metabolic, or sarcopenia complications, which are functional. This would be a severe sarcopenic obesity. If you go to treatment, you have to be careful, and this will be discussed further on, because if you think the patient as obese only, your usual aim would be to reduce cardiovascular risk and comorbidities, and you use all these methods. But some of these methods can reach into, put the patient into problems, especially increased sarcopenia. And if you approach the patient from the sarcopenia point of view, and you make that patient get better nourished and get supplements and get higher calories, the sarcopenic patient may become more obese or have the complications of obesity. So treatments are complex, and as shown by Peter before, you need to go to the appropriate nutrition, which includes reduced calories but also increased protein, and the appropriate exercise, and both together. Of course, there are other options, pharmacological, other medical therapies. These are not used in older people. We don't know if they're safe in older people. We know that people who lose weight for bariatric surgery lose a lot of muscle mass and function, so we have to be careful when people age, perhaps not in a 40-year-old, but yes, in a 60-year-old who gets the operation. So all this below, you have to be careful with them. To finish, Peter mentioned the zowel, and the JPI-initiatief, which is trying to increase and improve research in older persons with sarcopenic obesity, is discussing many things that will be discussed here and you will be thinking about. Can a specific diet be recommended? A specific nutrient? What would be the right exercise recommendations for these people in sarcopenic obesity? Are other therapies appropriate? What about calming drugs? And what's the role of bariatric surgery in sarcopenic obesity of any age, but very especially in those who are older, who are those at risk and are not currently being properly treated? This is why we started the So Nuts. This is an example of some of the papers already published, because we agreed on looking at when old age starts. That's usually when you retire. And how can we adapt habits of people? And that includes you, and perhaps your parents, because some very young people here. How can you adapt in order to change your activity and change your nutrition in the right direction so you prevent disability and the complications of obesity? So I do hope this introduction was enough for you, and I'm sure now you'll hear much better presentations by the next speakers. Thank you.
Thanks a lot, Alfonso, for this very nice overview. Alfonso will not be able to join at the panel session later this morning. So if you have any questions, suggestions, please ask them now.
I left 8 minutes for questions. If not, I can ask you.
So I have a question. I'm a dietitian, and I see a lot of people who had stomach surgery. And so I think it's important to have these 20 grams of protein through the meals. But I have a question about that type of that group with reduced muscle, reduced stomach. How to achieve that? Because they can eat small portions.
Mm-hmm. That's a good question, a bit away from my field. One of the things, the unanswered questions, is that we don't have long-term longitudinal follow-up of these people. So we know that recommendations for adults would be 0.8 grams of protein, and after they go over 60 to 70, they should increase to 1.2. But we don't know about these young people who have been operated. If you need to start earlier with a higher amount of protein, we don't have that evidence yet. So that's an issue. The second, probably there's people more apt to explain you tricks to do that, but what you have to use is probably more hours along the day to give the proteins in different ways. But I'm not an expert in that. I cannot answer better than that. But I would be careful about we don't know the right amount of proteins for these people.
Thank you for a very nice overview. I'm a bit worried myself due to the plant-based discussion these days that everyone should eat as plant-based as possible to save the planet. But this, I don't think this applies to people that are at risk for sarcopenic obesity, because their protein intake tends to get too low. And it already is low in elderly people, we see when we talk to patients. So what's your view on this?
Yeah, my view on this is that at this moment, what we know, we have evidence, is that the amount of proteins is more important than the source of proteins. So if I had an older person, I would prioritize having the right amount of proteins over where they come from. If you can get them from the diet that's appropriate for them or they enjoy or whatever, it's okay. But if not, use any method to reach the proteins. The second thing is the only real diet that we know reduces disability and diabetes in many aspects is Mediterranean diet. Mediterranean diet, most of the proteins come from legumes. They're not, it's only recommended once a week, red meat, and from legumes and white meat and fish. So perhaps you can use this Mediterranean framework because we know that's healthy for not only for sarcopenia or obesity, but also for many other aspects. And that may be the framework to shape the diet of a person.
Question from me. Many people in general public, of course not in this audience, might say, why bother with nutrition, exercise, and even technology? It's such a hassle, it's a lot of work, give me a pill. And there are drugs on the market. Mm-hmm. Maybe very effective. What is your...
You mean for obesity?
Right.
Yeah, because not for sarcopenia, and they're not so close. Yeah, the question is, what's your objective when you age? Because if you ask young people, they don't think about it. When you start growing old, in your 50s or 60s, you start thinking. And in most surveys, people say, what I don't want is to become dependent of others physically or mentally. That's the most frequent answer. So I want to age, but be independent. So the question when someone wants a pill or to lose weight is, what do you want when you are old? Why are you losing weight? It's only for the shape, because you look well? Are you going to look for, go to a disco or something? Or do you want to age well, and what's aging well for you? And if aging well is for you, and I give you a pill, and you lose a lot of weight, which is mostly muscle, I might put you at risk of being dependent of others for many years. So my question would be, what do you want for yourself? No, I prefer to lose weight and I don't matter. It's okay. It's your decision. I might help in your decision, but it's an informed decision that you are increasing your risk. And it's an individual thing, I think.
Thank you, Alfonso. I hope that many doctors in Europe will share your opinion on this.
It's easier to give a pill than to explain things. But we are assessors of and trying to help people age well. And for that, what we have to say is the truth based on science.
Hi, thank you. Erik Voor, and I'm working as a researcher at the Amsterdam UMC. And I'm actually involved in neuromuscular diseases. And I'm struggling a bit in neuromuscular diseases. And I'm struggling a bit with how to use the concept of sarcopenic obesity in this context, because clearly there is a different pathophysiology in case of neuromuscular diseases. So I was just interested in your perspective on this.
Yeah, I think it's good that you're doing research because nobody knows. Yeah, what we know is that in sarcopenia there's a component of neuromuscular aging. You can read works by Clark, Brian Clark, he wrote a very nice review in the Journals of Gerontology 2 years ago on all the neural aspects. So it might be that some sarcopenic patients have a more important neural involvement than we think, and those would not respond to nutrition and might only respond to exercise. But as for neuromuscular diseases where the problem comes from the neural part, we don't have data. It's not so frequent and we don't have data. So you need to approach. It might be that you have to go more to the field of cachexia than to the field of sarcopenia.
Other questions?
It's perfect because it's 1 minute to 10, so now they can introduce the list. Thank you, and sorry for not being able to stay later. Thank you
very much.